So, hello everyone, a very good day to all our dear students. Thank you for joining in and a warm welcome for today's webinar by Dr. Ramya. But first, let me give you a quick review about our MRCOG-1 course, okay? So let me introduce you first to our team of expert mentors. So we have Dr. Mohammed Halmi and Dr. Jazri. Along with these mentors, we have Dr. Maryam, Dr. Ramya, and Dr. Mavish. And we are basically conducting a regular course, but in the regular course, we are following a study plan so that our students can prepare easily for the exams, okay? So we have divided the regular course in 3 phases. So we have the pre-course phase, the live session phase, and the revision phase. So in the pre-course phase, we are going to give recorded session to our students so that they can start their preparations, okay? And we are also giving mini mocks so they can attempt on the website. And in the live session phase, our expert mentors are going to conduct live sessions with the students and they are going to teach you, and then you can have discussion in the study group, okay? I'm going to explain these phases in detail afterwards. And in the third phase, that is the revision phase, we are going to revise that we have covered in the pre-course phase and the live session phase. So basically, in the pre-course phase, these are the features that we are offering to our students. We are going to give you recorded lectures along with the PDFs that you can watch and you can prepare, okay? And after watching those sessions, we are going to conduct discussions in the study group. Along with that, we are going to give you mini mocks that will contain question answers from the past papers that are going to help you to prepare very well, okay? Also, the books and important files are also available on our website portal that you can avail, okay? Now let me talk about the live session phase. So in the live session phase, we are going to give you a schedule in which we are going to tell you about all the topics that we are going to cover in the live sessions, okay? So our live sessions are not the typical ones. We have covered all the 14 subjects that are necessary for the exams in the live session schedule, okay? And along with the live sessions, we are going to give you the PDFs and the recording of the live session that you can watch anytime till the course. Also, we are giving you topic tests for each topic and the flashcards. Along with that, you will be having biostatistics workshop that our expert mentor, Dr. Jazri, is going to cover. And of course, the support, the technical support, you're going to have it till the course, okay? Now, the third phase, in the revision phase, we are going to revise all the topics that we have covered in the pre-course and the live sessions, okay? And in that, we are going to give you booster mocks exams that will be exactly like the RCOG exams so that you can have a real-time exam experience, okay? So basically, this is our live session schedule that you can see. We have mentioned the dates, the topics that we are going to cover in the live session phase, and all the mentors or expert mentors, they are going to conduct the live sessions on Zoom application, and they are going to cover all your queries in the live sessions. So these are basically the feedbacks of our beloved students. You can see how they were pleased with the courses. Now, let me tell you one more thing, that we are also giving free library that contains the question pool for each topic, all the topics that are necessary for the exams. So to access that, you have to download our application from the Play Store or Apple Store, and you're going to access the free library. Our customer support team will be available. We are here to guide you how you can access the library, okay? Now, here is the gift for all the participants who have joined today. We are going to give you 60% off on our MRCOG regular course. You can comment in the chat box. Our team is going to help you in that. Thank you so much for all the attention. Let me, please, Dr. Ramya, can you proceed with the topic?
Yeah, thank you so much for that brief discussion. So, very good evening to all of you. I myself am Dr. Ramya Sree. I will be discussing a short topic now, that is cervical incompetence. So, we are going to discuss the cervical incompetence in especially because we have a new updated guideline on the cervical incompetence. So we'll be discussing the cervical incompetence for the, I'll be mainly discussing the guideline of the cervical incompetence. So first I'll give you the basics of the cervical incompetence guideline, and then followed by I'll be discussing some MCQs on this. Okay. So coming to the preparation of part one preparation requires all 19 subjects, and yes, we'll guide through entire 19 subjects. So just give me 1 minute. I would like to share my, so can I share my screen also?
Yes, ma'am, you can share your screen now.
Okay. Just 1 second, guys. I'm starting it. Just 1 second. Um, uh, can, who's there along with me to support from med exam? Sabha?
Dr. Ramya, I'm available.
Yeah, actually, I'm trying to share it, but I'm using the iPad. So it is share content. So what should I do? Is it like photos or iCloud Drive or Dropbox? Which one I should do it?
Ma'am, you have to click on the drive if it's uploaded on
iCloud
your
Drive.
drive.
Okay. Okay. Right. So is it visible?
Yes, ma'am, it's visible now.
Right. So very good evening to all of you. Myself, I'm Dr. Ramya Sree. I'll be discussing the cervical incompetence guideline. So what do we mean by cervical incompetence? So what do we mean by cervical incompetence? Very good evening, Marina. Very good evening, Dr. N. Graham. So I hope now I am audible to all of you. Yes. So very good evening, Sumaira. Good evening to all of you. I'm very happy to see you all right? So what do we mean by cervical incompetence? What do we mean by cervical incompetence? So cervical incompetence is where cervix is weak enough. So cervix is weak enough to hold the products of conception. The main clinical presentation, what we'll have for cervical incompetence is so usually they'll tell everything would have been all right for the first trimester. Second trimester, they'll complain that they're like they were washing clothes or they're washing utensils, and suddenly the membranes broke and the entire baby has come out, right? Yes, very good, Humera. They can also complain that there will be preterm labor, right? So there can be preterm labor or they can be second trimester miscarriages, right? So these are the two things which we see with the cervical incompetence. Now, the guideline for the cervical incompetence or the cervical cerclage is mainly given telling us what are all the conditions where we have to put the cervical and cerclage. What are the conditions where we should avoid cerclage? So these are the basic points which the guideline tells us and which we'll go through in this session, right? Right. Is my screen visible to all of you?
Yes, ma'am.
No, I don't want this one. I want actually, yeah. Okay, so what are the conditions which can cause cervical incompetence? So can you guess some conditions where we can have cervical incompetence? So cervical incompetence will be obviously seen in those conditions where there can be some trauma to the cervix, right? So what are the conditions where we can traumatize the cervix? First and foremost, there can be congenital weakness. So congenital weakness can be developing anomalies, developmental weakness of the cervix. So where cervix has developed very weak. So it can be some connective tissue disorders or, following in utero exposure to diethylstilbestrol or some uterine anomalies. So that is congenital. Or it can be acquired where we have done some surgeries, on the cervix, which has traumatized the cervix. So where we traumatize the cervix, when we have done forcible dilatation during MTP or DNC. So normally what is the instrument which we use to dilate the cervix, guys?
Cervical dilators, madam.
Yeah, which are the,
Hager's
can you name any
dilators.
cervical dilators?
Hager's dilators.
Yes, so most commonly we use the Hager's dilator. So when we're using the Hager's dilator, we multiple times when we do DNC, that can traumatize the cervical tissues, right? Or when we are doing surgeries like conization of the cervix, like for CINs, carcinoma in situ, or stage 1A1 cancer cervix. So where we are doing conization of the cervix, or where we are burning the cervix, cauterization of the cervix, or when we are doing amputation of the cervix or Fothergill's operation. So normally the Fothergill's operation or amputation of the cervix is done for the multiparous lady who has completed her family, right? So it's also called Manchester's operation. So these are the first conditions where we can traumatize the cervix and we can suspect that they can go into cervical incompetence. Now, very important, per se, these are not the indication for cerclage operation as per the RCOG guidelines. So that is the importance of the guidelines. So he doesn't tell, it doesn't mean like if they have this complication or these causes, we can go put a stitch. So there are certain guidelines. When should we put a stitch? So that I'll be telling you in some time. So first, let me give you a brief. Now, how do we identify? How do we identify if somebody is having cervical incompetence? So they will mainly present to you with painless cervical dilatation, followed by rupture of membranes, followed by expulsion of the fetus. Most of these patients will present to you with second trimester miscarriages. Most of these patients will present to us with second trimester miscarriages, right? Will it be painless loss or painful loss?
Painless loss.
Yes, very good. So usually these are the painless loss, right? Now next, how are we going to diagnose this? So in the non-pregnant state also, we can find out whether they are having cervical incompetence or not. So how do we find out in the non-pregnant state whether they're having cervical incompetence or not? When OS allows easy passage of number 8 Higgins dilator, when OS allows easy passage of number 8 Higgins dilator. So normally when you're passing the number 8 Higgins dilator, after the dilator goes inside, you should hear a click sound. So that's called snap test. So when you're passing the Higgins dilator through the undilated cervix, so once it passes the internal os, you should hear a sound, no? Because it is going with great difficulty. But when we have cervical incompetence, this click sound won't be there. It will be very aram se, it will be easily going inside. Or 1 ml Foley's catheter can also easily pass. Or 1 ml Foley's catheter also easily pass. Yes. Next, when you're doing HSG, you will see funneling of the internal os. When you do HSG, you will see the funneling of the internal os. Right? Now, is funneling of the internal os an indication for cerclage operation, guys? What do you think? Funneling of the internal os, is it an indication for cerclage operation?
No, ma'am.
No.
No,
So according to the guidelines, the simple funneling of the internal os is not an indication for cerclage operation. Is there a disturbance in my voice?
no.
Okay. So it's not for everyone. I think those who are facing it, Ufaq. So can you check your internet? Right. So per se, just on HSG, if you see funneling of the internal os, it is not an indication for cerclage. It's not an indication for cerclage. The most important, all the MCQs, what they'll be asking is mainly based on the what are the indications where cerclage is indicated. So those are the things which we should be knowing, right? So this is not an indication, absolutely correct. Now, during pregnancy, how do we identify that if somebody is having cervical incompetence? So it is mainly by seeing the cervical length. So cervical length
TVS.
on TVS. Again, most important, it is on TVS. Yes, what is the cutoff for cervical length? Anybody can answer?
2.5 to 3.5 cm.
2.5 centimeters. So if somebody's cervical length is less than 2.5 centimeters, it means that, yes, he might go into cervical incompetence. Now I have one question, guys. So if you have done a scan, let us take for a the cervical length to be less than 2.5. Will you insert a cerclage operation for her?
If there is competent, if there is a healthy cervix, then we can put it. If it's no, deficient cervix, then we will try also to put it.
So that is what our guideline says. Just by per se. So if she doesn't have any other history, and if she's a primary gravida, and if her cervical length is less than 2.5, it is not an indication for cerclage. So for such patients who's a primary gravida, who doesn't have, yes, so it may very good Nafia. So it mainly depends on the previous history. So if she's a primary gravida and if she doesn't have any history of cervical preterm labors or anything, then just the cervical length less than 2.5 is not an indication. Okay. But yes, cervical incompetence is diagnosed by cervical length less than 2.5 centimeters between 16 to 24 weeks of gestation. Between 16 to 24 weeks of gestation. I really appreciate the way you're all participating. That's really wonderful. So till now, what I've discussed is, I told you what are the indications, what are the causes for cervical incompetence. So wherever we have the cervical trauma, we can have cervical incompetence. Followed by, I told, we can diagnose, they present mainly with painless preterm labor or second trimester losses. Next, I told, how do they how can we diagnose them, right? And these cervical incompetence, when you see them on ultrasound, usually the cervical incompetence, when your serial ultrasounds you do, this is how they progress. So a competent os will look like complete T. A competent os will look like a T. Then when she's trying, when she's going into, as it is undergoing miscarriage, then it will become Y. Upper part will be open, but lower part will be closed. Then it will open from above to below. Then it will be open from above to below with bulging of membranes. Then it will open from above to below with bulging of membranes. So the pattern of opening of the cervix on the USG is TYVU. TYVU. Competent os is T, whereas incompetent os will start with Y and ends at U.
Okay.
Next, what are the indications? Now, this is most important for our discussion. So this is the main important discussion. So what I gave you is a brief till now. So this is the most important. Now, as per RCOG, so our new RCOG guidelines has been introduced in 2022, guys. So I am speaking everything from the 2022 guidelines. So RCOG 2022 guidelines, I'll be highlighting in this session. Okay?
Okay. 2022.
So yes. So first thing, the indications for cerclage remains the same. We have history indicated, we have USG indicated, and we have rescue cerclage, right? So history indicated cerclage is when a woman with singleton pregnancy who has 3 or more previous preterm births, she should be offered the history indicated cerclage. So when woman has previously 3 or more previous preterm births or second trimester pregnancy loss, she should be indicated for history indicated cerclage.
With bad obstetric history.
Yes. So, and very important, he tells that history indicated cerclage should not be offered to women with less than 3 previous preterm births or second trimester losses without additional risk factors. So if they don't have any additional risk factors, and if they have less than 3 previous preterm births or second trimester losses, then you're not going to put a cerclage operation. So you can put a cerclage operation only when they have 3 or more based on the history indicated. This is the point number 1 which we have learned. So this is the point number 1 which we have learned. So I will see to it that, see, you have given your precious time here. My main motto will be, I'll make you thorough with this guideline. So I'll see to it that with this session, you become thorough with this guideline. So that will be the main motto. So I'll just pressurize on the points which are most important and which should be imprinted in your brain. So first is, when can we put a cerclage? We can put a cerclage only if there is a singleton pregnancy with 3 or more previous preterm births. Now, what is USG indicated cerclage?
Depending on also decrease in cervical length or not?
No, not dependent on cervical length. Thank you for asking that. So if they have 3 or more previous preterm births and this pregnancy, whatever might be the cervical length, doesn't matter. You can put a stitch. That is why we can also call this as prophylactic cerclage.
Prophylactic cerclage.
Because you're putting, because she already has 3 or more previous preterm births, it means definitely she has cervical incompetence. And the shortening of the cervix will be progressive. So probably when you do the first scan, let us take that at 7th scan. Let's take that if the patient has come to you at 7 weeks and you see the cervical length as 3 centimeters. So it doesn't mean that you will not put a cerclage. So these patients, you should put a cerclage, and all these history indicated or elective cerclages are usually done at 11 to 14 weeks of gestation. At 11 to 14 weeks of gestation after you perform the NT scan.
About point
Okay.
number 2, This is not offered to women with less than 3 previous preterm. This is also depend on even if there is the decrease in cervical length also not offered.
No. If they are having less than 3 births, but cervical length is less, then you have to offer. That is only our second indication. I'll tell you the second indication. See, I'll tell you the second indication. Second indication is where they have the cervical length less. So next is ultrasound indicated cerclage. So ultrasound indicated cerclage is done for those women who is singleton again. Yes, Sumaira, we'll come to the post-op complication as well as pre-op. First, now we'll see all the indications. So first, I'll tell you what does ultrasound cerclage means. Ultrasound indicated is what you have, what just somebody of you, just now somebody has asked, no? So if she has previous preterm birth and now cervical length is less than 2.5 centimeters, then you have to put a stitch, and that is called ultrasound indicated. So ultrasound indicated is for a woman with history of 1 or more spontaneous second trimester loss of preterm birth. And when you're doing ultrasound surveillance for her, and if cervical length becomes less than 2.5 or less than 24 weeks, then you should put a stitch. Am I clear with the second point also? Whom you should put a cerclage?
Yes. Yes. Thank you.
Yes. Okay. Now, ultrasound indicated if you have a singleton pregnancy. And in singleton pregnancy, if cervical length comes when you have done a scan, let us take that cervical length is less than 2.5 centimeters. Will this be an indication for cerclage?
No, ma'am.
No. Yes. So insertion of cerclage is not recommended in women with short cervix incidentally. So for them, what will we do? It is a singleton pregnancy and cervical length has come less than 2.5. So for them, we'll do serial ultrasounds. Okay. So we have learned two things here, that mainly ultrasound indicated is done for a woman with history of 1 or more spontaneous second trimester pregnancy loss plus cervical length less than 2.5. If it is a singleton pregnancy and if cervical length is less than 2.5, then it is not an indication for cerclage. As well, as I already told you, funneling of the os is also not an indication for the cerclage. So ultrasound indicated cerclage is not recommended for funneling of the cervix in the absence of cervical shortening of 2.5 centimeters. Okay. Now, whom should we offer serial sonographic ultrasound?
Those who are less than 2.5 cervical length.
Yes, excellent. So those who are less than 2.5 and we are not putting a stitch, no, for them, you can offer a serial sonographic surveillance. So with a history of a woman with a history of spontaneous second trimester loss of preterm birth, who have not undergone history indicated cerclage, may be offered serial sonographic surveillance. And when you're doing serial ultrasounds, no, then if cervical length less than 2.5, then you can put a cerclage for her. Okay. You also have one
After
more
how long
indication.
do we do ultrasound in serial sonographic surveillance? After how long?
Usually up to 24 weeks.
Okay.
Yeah, because anyway, after 24 weeks, the period of viability is attained, right?
Okay.
Doctor, if patient has history of previous one preterm delivery or birth, but she has cervical funneling in the ultrasound. So it is indicated for the cervical cerclage for such patient?
So if she has a cervical funneling, but cervical length, so they will definitely mention what is the cervical length also, no? So if she has cervical length, cervical funneling, but cervical length is, let us take, more than 3 centimeters, then she's not indication.
If less than if less than 2.5 centimeter, the previous one history of preterm labor and funneling, then we will go for cervical cerclage.
Yes. Yes.
Okay, fine. Thank you very much.
Yeah. So I have a question. Dr. Rafia, we are discussing cervical incompetence and we are going through the cervical cerclage RCOG guidelines. I'm guiding them regarding what are the indications of cervical encerclage. Dr. Sabha, we never give prostaglandins. Prostaglandins will cause contractions. Indeed, what can be given? What we think we give, actually what we give in practice is not prostaglandin. I think what can we give?
Progesterone.
Yeah, progesterone. So we give
progesterone.
Yes.
Yes, progesterone supplement.
Somebody asked something. So
No.
Yeah, normally we give. Yeah, yes. I thought so. You're writing progesterone itself. Okay, one more as Sabas put forward regarding this progesterone. I'll also speak about progesterone here because guideline also speaks about progesterone. So usually in our practice, we give progesterone. We give it so much. But guideline says progesterone is also not indicated. Guideline also says bed rest is not indicated. Right?
Okay, ma'am.
Okay. Yeah. So, Purnima, so when should we offer serial sonographic surveillance is a woman who has history of spontaneous second trimester loss or preterm birth, but if she has not undergone history indicated cerclage, for her, you can offer serial sonographic ultrasound. For her, you can offer serial sonographic ultrasound. And how long you can offer? 1 second. How long we can offer? So we usually offer it up to 24 weeks. We usually offer it up to 24 weeks. And one more thing. If some patient presents to you with at 24 weeks, after 24 weeks, less than 2.5, then you can continue the pregnancy same way. Usually they don't go into preterm labor.
Yes.
Yes. So cutoff length. Yes, Dr. Devika. The cutoff length for cervical incompetence is 25 mm. So non-pregnant pregnancy may the normal length of the cervix in pregnancy, the normal length of cervix is 4 centimeters. Is 4 centimeters. Whereas when we'll call cervical incompetence, when cervical incompetence is called when cervix is less than 2.5 centimeters. Okay. And we have one more query. So serial ultrasound is where every 2 weeks you will do a cervical ultrasound.
Fortnightly.
Yes, every 2 weeks. So fortnightly you are going to do the ultrasound. Now let me give you another clarity in whom we should do the cervical ultrasound surveillance. So that also has been mentioned in the guideline. Let us just go through that. So women at high risk. Women at high risk.
Like GDM, previous GDM, diabetic, previous MRCOG-1.
Yeah. So women at high risk included for the serial ultrasound. Those with a previous preterm birth or second trimester loss, previous preterm pre-labor rupture of membranes before 34 weeks, those patients who have previously used cerclage, when they have uterine abnormalities like septate uterus or biconvate uterus, or when they had history of intrauterine adhesions, or those women for whom we have done trachelectomy. So these patients are told they should go to the preterm specialist by 12 weeks, and then we should do a transvaginal sonography every 2 to 4 weeks. The guideline says every 2 to 4 weeks. between 16 to 24 weeks. Between 16 to 24 weeks. Now, I repeat, what is this? I'll repeat just 1 minute. You can all listen to me. So, whom are we going to offer serial ultrasounds? Those patients who are at high risk of developing cervical incompetence and those who are going to go into preterm labor, those are at those people we should offer the cervical transvaginal sonography every 2 to 4 weeks between 16 to 24 weeks. Now, who are those patients? So those patients who have previous preterm birth or second trimester loss between 16 to 34 weeks of gestation, those patients who have previous preterm pre-labor rupture of membranes before 34 weeks, those patients for whom we have done cerclage operations previously, those who have uterine variants, those who have intrauterine adhesions, those whom we have done trachelectomy operation. Does anybody know what is, can anybody give me a brief, what is trachelectomy?
Removal of the cervix.
Removal of the cervix for what?
Removal of the uterine cervix.
Yes.
Removal of cervix in cervical cancer.
Upper part of vagina and surrounding supporting structures.
Correct. Excellent. All of you have answered correct. So trachelectomy is done. Trachelectomy is removal of the cervix till cancer-free margin along with the ligaments and lymph nodes. So this is done for the cervical cancer stage 1A1 to stage 2A1 except 1B3, those patients who want to preserve their uterus. Right. So these are the points for whom we should do TVS.
Ma'am, for which stages? Stage 1A1?
2A1. 1A1 to 2A1.
2A1, okay.
Except 1B3.
1B3, okay. Got it.
Right. Now, there are also certain patients who are at intermediate risk. So what are the patients who are at intermediate risk? So the intermediate risk patients are women with history of previous full dilatation cesarean section, or for whom we have done large loop excision of transformation zone, or for those women who we have done bone biopsy. So these intermediate risk patients, you should just do one single TVS between 18 to 22 weeks. We have to do only one single TVS between 18 to 22 weeks for intermediate risk patients. Okay. So this is about the whom we should offer the screening and whom we should do the surgery directly. Okay. I just repeat 2 points to all of you now. What are the indications? Does anybody want to repeat what are the indications for doing cerclage? Anybody want to take an initiative to tell what are the indications for doing cerclage operation?
A patient with singleton pregnant. Oh, sorry. We cannot do in singleton primary patient, but a patient with single pregnancy with history of previous second trimester miscarriages or preterm losses.
Okay. So she has told ultrasound indicated. So ultrasound indicated is where a previous second trimester loss or preterm labor plus TVS showing cervical length less than 2.5 centimeters. Okay. What is the another indication?
Ma'am, history indicated shows 3 or more spontaneous losses in second trimester.
Very good. Excellent. So history indicated is when they have previous more than or equal to 3 second trimester loss or preterm labors. Do we bother about what is the cervical length in these patients?
No, ma'am.
No. Very good. Excellent.
We are putting prophylactic cerclage.
Yes. So that's also called prophylactic cerclage, right? So these are the 2 indications. Apart from this, guidelines also says one more cerclage that is called rescue cerclage or emergency cerclage. So rescue cerclage or emergency cerclage is where cervix is already dilated. And if you are putting a stitch, then you call it as rescue or emergency cerclage. As of now, we have completed two things. One is what are the indications, which all of you have answered. That's excellent. Second point, what we have learned is what are the indications where you will do serial ultrasound monitoring, right? Can anybody tell me what are the indications where we'll do serial ultrasound monitoring? You cannot tell all, so I'll just keep that slide so that, some you can answer from here. Yes, very good, Nafia. High risk patients. So can you name at least few high risk patients?
With previous preterm birth or second trimester losses, 16 to 34 week gestation.
Yes.
Previous use of cerclage.
Yes, excellent.
Uterine septate or bicornual uterus.
Very good, Humaira, correct.
Stage 1A1, 2A1 surgical patients in which trachelectomy was done.
Excellent, yes.
Or in the uterine
FORM, less than 34 weeks.
Very good.
Pre-prom.
Rupture. Yes. And one last we have left is intrauterine adhesions. Now, who will tell me how frequently we will screen and from when to when we will screen these patients?
Every 2 weeks.
Every fortnightly.
Every fortnight, and we have to start from when to when?
16 to 24 weeks.
16 to 24 weeks. Very good.
Weeks is a tough point.
Yeah, actually, very good, Gayantika. So guideline says every 2 to 4 weeks. It doesn't tell every 2 weeks. It tells every 2 to 4 weeks between 16 to 24 weeks. Okay. Right. And intermediate risk are when we have done some surgeries on them, like conization or LEDs or LEAP, or if they have full dilatation C-section. And in them, one scan he has told, one scan to repeat again at around 18 to 22 weeks of gestation. Now, he has given in the guidelines different situations, and he has asked, what will you do for these patients? Like for multiple pregnancy. So is per se just multiple pregnancy an indication for cerclage?
No.
No. So multiple pregnancy is not an indication for cerclage.
Unless there is previous history of 3 losses or second trimester losses.
Yes. So only just multiple pregnancy without any other risk factors is not an indication. Right? So not an indication for cerclage. They should have some other associated, then we can put a stitch. Right? Next, let us see what is the next one he tells. So when there is no additional risk factors, even so cervical surgery or trauma or uterine abnormalities, just per se is not an indication. These all are not an indication for cerclage, but these are all indication for what?
Serial ultrasound.
Yes, they are all indication for serial ultrasounds, not directly for cerclage operation. Yeah, and one thing which
Doctor, what about the infertility?
So yeah, these patients are just for monitoring. Now, next he tells those women who are with raised BMI, for them cerclage is effective. Cerclage is effective in women with raised BMI.
BMI more than 5?
BMI about 25.
Okay.
BMI about 25. His studies gives that it is more beneficial. So when BMI is more than 25 and cervical length is less than, again, it doesn't mean cervical length should be anything. So about 25 and cervical length less than 25 mm. So they have done a study. And they found that whose BMI is high, for them cerclage was beneficial in preventing the preterm labor. Okay? Right. So now I'll give you a brief. What are the different types of cerclage operations available? What are the different? So till now we discussed what are the indications for cerclage. Now we will see what are the different types of cerclage operations available. So this is one cerclage operation. Actually, this is the most common cerclage operation, a pursue string suture, which we do from, is it transvaginal or transabdominal? Yes, it's a transvaginal or transabdominal.
It's McDonald.
So it's a transvaginal, right?
Transvaginal.
Yes. So this is a transvaginal cerclage. This is a transvaginal cerclage, which is done. It's a pursue string suture. It's a pursue string suture. The second stitch what we have is, so McDonald is put here. McDonald is put here. Second stitch what we have is Shirodkar cerclage. Shirodkar cerclage is put after the bladder is separated. Shirodkar cerclage is put after the bladder is separated, and it is put at high level from the cervix. So it is at the as high as possible on the cervix. So here we put McDonald. Here we put Shirodkar. Whereas when you do abdominal cerclages are at cervico-isthmic junction. Abdominal cerclages at cervico-isthmic junction. I repeat again. So McDonald is wherever you are seeing the cervix transvaginally, the highest part. Shirodkar cerclage is at the bladder sulcus. So you separate the bladder and then you go as high as possible near the cervix and then you tie it off. Abdominal cerclage, you put it the cervico-isthmic junction. The one name of abdominal cerclage is Benson and Durfee. Now, what is the suture material which you use for cerclage operation? What is the suture material which you use for cerclage operation?
Non-absorbable.
Excellent. He just tells it is non-absorbable, whichever you are comfortable, right? Yes, Sabha, excellent. Usually we use silk or we can use ethylone also. Silk or ethylone. So it should be non-absorbable. It should be non-absorbable because we are going to anyway remove it. We are going to remove it, right? Next, what should be the pre-op investigation? So this is modified Shirodkar where you're separating the bladder and then as high as possible, you're taking the cerclage. Most commonly done is McDonald. Most commonly done cerclage is McDonald. Guys, next point. What are the pre-op investigations which you're supposed to do when you're doing a cerclage?
Cervical swab.
So he tells first you have to do a first trimester ultrasound scan and screening for aneuploidies. Very good. NT scan. Why NT scan is important before you do a cerclage operation?
Ma'am, to rule out any anomalies.
Yes. What is the purpose of doing a cerclage when you have an abnormal baby? So NT scan and aneuploidy screening should be done. Very good, Nafia. Very good. So if ultrasound indicated or emergency cerclage is there, then you have to go for anomaly scan. Depending on when you are doing the scan, if it is an emergency or ultrasound indicated, then you will go for anomaly scan. Yes. So it is depending on the gestational age. Next, white cell count and C-reactive protein can be used, but it is not like mandatory. Maternal white cell count, maternal WBC count, and C-reactive protein can be used, but it is not mandatory. Can be used, it is not mandatory. Now, before cerclage, amniocentesis or amnioreduction to find out any chorioamniotis, those are not indicated. those are not indicated. And routine genital tract screening, that is swab, is not indicated.
Okay.
Okay. But if you find a positive culture from the genital swab, then you have to delay, because you cannot put the stitch when there is infection, right? So what are indicated according to him? NT scan and aneuploidy screening, anomaly scan if she is a second trimester, if you're putting a stitch, and maternal WBC and CRP can be done. There is nothing wrong in doing maternal WBC and CRP, right? What he is telling, insufficient evidence is amniocentesis and amnioreduction. Amniocentesis and amnioreduction. So normally in emergency cerclage, when you have bulging membranes, no. So what we used to do is we used to reduce some amount of fluid and then do a cerclage. But he tells absence of data to support amnioreduction, right? And routine genital tract screening. Routine genital tract screening is not mandatory. Next, before operating, tocolysis. Is tocolysis indicative before operation?
No, ma'am.
No, doctor, it's not indicated.
No, not indicated. So tocolysis also, there is no evidence to support the tocolysis. Preoperative antibiotics, depending on your hospital, you decide. Preoperative antibiotics is according to the operating team, right? And anesthesia also, choice of anesthesia also should be made by the operating team itself. Okay. And usually these are daycare procedures. So safely performed as a daycare, and then we discharge the patient, right? Bed rest, not indicated. When should we start the sexual intercourse post? So sexual intercourse can be resumed immediately. There is no point telling that you should delay the sexual intercourse. So abstinence following sexual intercourse is not indicated. Sorry, following cerclage.
Doctor?
Okay. Now, where do we use fetal fibronectin? Where do we use fetal fibronectin?
Ma'am, to see about preterm labor.
To
Between
detect the
22
preterm
and
labor.
34. Yeah, between 22 and 24 and 34.
So fetal fibronectin can actually predict the preterm labor. So there is no role of fetal fibronectin or progesterones or bed rest. So actually whatever we have learned, no, apart from that rest all, it is no role. So instead of remembering what is no role, I feel you remember what is having a role. Don't you think that is better? Because guidelines goes on telling what is no role. I always feel it's better to remember what has role. Rest all, whatever comes in the exam, you can answer as no role, right? So what I have discussed now is there is no role of cerclage in the twins. There is no role for any surgeries or uterine anomalies. For them, we mainly have to go for serial ultrasonic monitoring, right? There is no role of progesterones or bed rest or post-cerclage ultrasound monitoring or fetal fibronectin monitoring, right? Now, when should the
Excuse
cerclage
me?
be done? Yes,
I have a question.
Yes.
What do they mean by aneuploidy screen? Do they mean cell-free DNA? Because in emergency, we are only doing the ultrasound. So in elective cases, do we have to do cell-free DNA?
So aneuploidy screen, if they're affordable, you can always go for cell-free DNA. But per se, when you go for cell-free fetal DNA, it's expensive. Not every country can afford cell-free fetal DNA.
No, but they said in emergency, just go for anomaly scan.
Yes. For second trimester,
cases,
it is anomaly scan. And first trimester, NT scan and aneuploidy screening. So aneuploidy screening can be double marker also. So you can either do double marker or quadruple marker or NIPT.
Okay, fine. Thank you.
Yeah, but he doesn't tell like do only NIPT. Normally, NIPT is not a primary screening method.
Yes, sure.
Doctor, what about the infertility? There isn't any indication?
Can you repeat the question again?
For primary infertility, there isn't any indication?
For a prophylactic cerclage?
Yeah.
No. So that it's a good question. I'll tell you what. So imagine there's a primary infertility. First and foremost, cervical incompetence will never cause primary infertility. So primary infertility is those who have never conceived. Cervical incompetent patient actually can conceive, but they undergo recurrent abortion. So they're more prone for secondary infertility, right? So secondary infertility patients, we go for elective cerclage. And elective cerclage should be done between 11 to 14 weeks of gestation. Okay, Nafia, you're asking if IVF pregnancy, should we go for cerclage? No. Just an IVF pregnancy is not an indication for cerclage. Right? Okay, now next important is what are the contraindications of cerclage and what are the complications of cerclage. So the contraindications of cerclage are when we have active preterm labor, when there is evidence of chorioamnionitis, when there is a continuous vaginal bleeding, when there is PTROM, when there is a fetal compromise, or when there is a fetal defect or fetal death. When there is a fetal defect or fetal death. So I have written it a little better here actually. So contraindications are when they're having infection, when cervix is already dilated more than 4 centimeters, when there is an ongoing bleeding, when there is uterine contractions, ruptured membranes. Yes, when there are fetal anomaly, fetal anomalies, fetal death, and lethal fetal defects. Fetal death and lethal fetal defects. Okay, so these are all the contraindication. Complication, this itself can lead to abortion. This itself can lead to rupture of the membranes. This itself can cause bleeding, abortion, and chorioamnionitis. Very small risk of intraoperative bladder damage, that is like nothing. So mainly there can be ruptured membranes, bleeding, and this itself can cause abortion, and this can cause infection, right? So these are certain other side effects we can have. Yes, and abdominal cerclage, it can be performed both laparoscopic and laparotomy. Elective cerclage is done between 11 to 14 weeks, Rafia. Elective cerclage should be done between 11 to 14 weeks.
Well, ma'am, what about rescue cerclage?
Yes. So rescue cerclage is when cervix is dilated. If you put a stitch, we call it as a rescue cerclage or emergency cerclage. So normally rescue cerclage is done anytime when they come with a dilated cervix. Rescue cerclage can be done anytime up to 24 weeks when they come with a dilated cervix.
Okay, thank you, ma'am.
Dilation can be 3 centimeters.
And dilation can be up to 4 centimeters. Beyond 4 centimeters, you cannot put a stitch. Dilation can be up to 4 centimeters. Beyond 4 centimeters, you cannot put a stitch. Okay.
Yes, ma'am. Thank you.
Right. Imagine if you are. When should you remove the stitch?
After 24 weeks?
No.
37. Like it's like 34 to 35 weeks.
37 weeks.
37 weeks.
Or is
So
37 weeks.
37 weeks. So removal of the stitch should be done at 37 weeks.
Okay.
Or
But
if
in
the
case
patient
of
comes
preterm
in
labor,
labor,
we can remove
yes,
upon
we
admission.
have to remove. or if the patient comes in labor. So if the patient comes in labor at around 24 weeks also, at whatever gestational age, if she comes in labor, you have to remove. What happens if you don't remove the cerclage when patient has come to you already with labor pains?
Uterine rupture.
Cervical
cervical
yes.
Cervical trauma.
Cervical tear. It can cause uterine rupture also. It can cause uterine rupture. Very good, Gayantika. So yes, Rimsha, it can cause uterine rupture. So it's little dangerous. If they come with pains, if they come with labor pains, you have to immediately remove. Right. When you're putting an emergency cerclage, can you mute yourself? So if somebody comes to you with emergency cerclage, if somebody has come to you dilated cervix and you put an emergency cerclage, how long you can delay the pregnancy when you have put an emergency cerclage?
Till we can give the DEXA cover for the corticosteroids.
Yes. So when you're doing emergency cerclage, it doesn't mean that if she's 24 weeks, you can pull it till 34 weeks. It is only the maximum we can delay the pregnancy, or which the studies have shown is they can delay the pregnancy by approximately
48 hours.
days.
34 days. Okay.
In some cases. Okay. Right. And it has shown to reduce the risk of preterm birth. Twofold reduction in preterm birth before 24 weeks. Twofold reduction in preterm birth before 24 weeks. 34 weeks. So this is about the cervical incompetence, some important points, and regarding the guideline we have discussed now. Okay. So now shall we see some MCQs? I'll just show some MCQs to all of you now, so that let us see how the questions can be asked. A 28-year-old, gravida 4, abortion 3, second trimester miscarriage, attends the miscarriage clinic in view of poor obstetric history. Management is?
It should be B.
Very good. So what type of cerclage is this?
Elective cerclage. Prophylactic cerclage, sorry. Prophylactic
cerclage. So this is a prophylactic cerclage because she is already having
previous three second trimester miscarriages.
So it is the elective cerclage at 12 to 14 weeks. Next question. A 28-year-old woman presents to the labor ward with a premature rupture of membranes at 24 weeks of gestation. Abdominal examination reveals an absence of contraction, and a speculum examination reveals a 2 centimeters dilated posterior cervix. Management is? So Rafia, this prophylactic cerclage and history indicated cerclage are same. So ideally history indicated. This question you should be careful.
I think number A, not indicated.
It is patient already have as premature rupture of membrane, so it is not indicated to have cerclage.
So what should be the answer?
C.
It will be A.
See, although you know the answer, how you can answer wrong in the exams, that I'll show you. So MRCOG exam, no, it will have all options like very near. See, you told correct that she already has ruptured membrane, so you should not put a stitch. Is it not indication or is it contraindication?
It is contraindication.
What should be the answer?
D. No.
Elective cerclage is contraindicated. So answer should be D, not A, right?
Yes, ma'am.
Yeah. So this is how we can do silly mistakes in the exam. We should be very careful with that. We should be very careful. So all of you understood why the answer is D, not A or B or C?
Yes, ma'am.
See, that is why we are there, to help you out. While your preparation will guide you through these mistakes so that you don't do these mistakes in the final exam, right? Okay. Noted. What will be the management for her? Indications for prophylactic cerclages when she has 3 previous, right? No, prophylactic and elective cerclage or history indicated cerclage is same. Prophylactic, history indicated, elective cerclage is same. Better call it as history indicated. Okay, this is a very tricky question. Now, what are all the risk factors which she is having? I'll help you on answering this. So she's having, she's having bicornuate uterus. She's having large loop excision of transmission zone. But in spite of that, how much is her cervical length?
3 cm diameter.
Not indicated.
Yes. So she's having cervical length of 3 centimeters. So is cerclage indicated in her?
No.
No, ma'am.
Not
No.
indicated.
Right. So now no need of abdominal cerclage, no need elective cerclage at 12 to 12 months, 12 to 14 weeks. But what is actually indicated in her? Indicated in her was serial USG.
C, it will be, the answer will be C. Yes.
But here I didn't mention USG to see the length of the cervix. Already USG is done to see the length of the cervix. This option would have been correct. This option would have been correct if I would have framed the option as serial USGs to see the cervical length. Do you agree with me or not?
Yes, ma'am.
Yes.
So what is a better answer, A or C?
I think it will be A.
A
Yes.
should be, ma'am.
Yes, A will be the better answer.
Because length is already mentioned.
Yes. Length is already 3 centimeters, so no need of any stitch. So elective cerclage not indicated. What is indicated? Yes, and very good. Very good, Ahmad. Thank you for pointing out that. Patient also has mild vaginal bleeding, na? So definitely now not indicated, right? So we can just do serial USGs to her, but as we don't have that option, best answer is elective cerclage not indicated. So that is about the cervical incompetence. So did you all understand the session and was it beneficial for all of you?
Yeah, it was very nice.
Can you repeat? Excuse me. Can you repeat why not C?
Can you repeat?
Why is the answer not C?
Because
Answer.
already
So why the answer is not C is because here cervical length is 3 centimeters. So she is an indication for serial ultrasound. Already they have given the USG length. So why do you want to do USG to see the cervical length? So better answer would have been serial ultrasounds, right? Thank you so much, guys. So you will definitely have such innovative sessions from all of our mentors to all of you. So we are just going to make the subject easy for you through these sessions. That is the main purpose of these sessions. I am happy and you were all also very, very active and participating. That was giving me more energy actually, to be frank. I didn't feel a minute also that we are doing an online session.
Thank you, ma'am. Bye-bye. Take care.
Thank you so much.
Bye-bye. Take care, madam.
Bye-bye. Thank you.
See you soon.
Yeah, thank you. Definitely. Yes. Dr. Sabha, the previous question, there was a ruptured membranes. So as there was a ruptured membranes, we'll not put a stitch.
Yes.
Right.
And it was already 24-week gestation.
Yes. Right. Thank you so much, guys. I'll see you all in my anatomy session. Thank you so much. Bye. Have a good day.
Okay, bye-bye. Okay, ma'am.
Bye. Bye. Sabha, I'm leaving. So,
Doctor?
yeah, can I leave the session?
Doctor?
Yes, yes. Somebody's asking me a question. Yes.
Hello?
Yes, yes.
If have low-lying placenta, and the length is less than 2.5, so can we do cervical cerclage?
Actually, if you have a low-lying placenta, whatever might be the length, we cannot put a cervical encirclage. Low-lying placenta or
Even
anything
if
which
the cervical
causes.
length?
Yes. So because anything which has
Even the length
cervical. Yes. Even if the length is less also, you cannot put.
Oh, okay. Thank you.
Yeah.
Okay, bye. Take care.
Bye. Thank you.
Bye. Bye.
Bye. Bye.